Hello everyone, my name is Molly Bloodgood, and today I'm going to be presenting my case study titled Flesh-Eating Bacteria. So part 1, the case involves a 52-year-old male patient who presented to the emergency department with pain in his right arm, mainly in the forearm. He had a history of IV drug use and homelessness, and he was found by the police nearly unconscious and taken to the emergency room. Initially, his vital signs showed a blood pressure of 72/40, temperature of 39 degrees Celsius, respiratory rate was 19 breaths per minute, cap refill was 4 seconds, and oxygen saturation was 95%, and he was put on sepsis alert. His arm presented with erythema, pitting edema, and 2 to 3 centimeter wide bullae on the forearm. He was initially given Narcan intranasally, and a central line was started. And through this, they administered fluids and broad-spectrum antibiotics. He did have sensation when evaluated in the arm. He had touch sensation and he had slight range of motion. He could move his fingers, but not full range of motion. And an ultrasound showed that there was no deep vein thrombosis, so they ruled that out. And blood, urine, stool, and the bullae fluid was taken for laboratory analysis. So some questions for part 1 are, what are the indicators of possible sepsis? So why was he put on sepsis alert? What is Narcan and why would it be administered intranasally or even at all? How would you assess cap refill and why is that important? And what are the benefits of the central line and when might it be placed? So why in this case was it placed? And then what are some possible causes of the swelling and the localized edema of a body part? So part 2. The pathogen was determined to be Streptococcus pyogenes, and this is a group A strep. And it's a gram-positive cocci found in chains, as shown in the picture here. It is part of normal human flora. It colonizes the throat and the skin, and it causes pharyngitis, which is strep throat, most people know it as. And it's found in the environment, especially in water, especially if you have an open wound or an active infection. It is spread through aerosols, so strep throat is contagious if you're around other people. So other types of strep infections won't necessarily be as infectious from person to person. Some of the virulence factors include the M protein, toxins, and enzymes. And it also thrives in oxygen-free environments. Some of the virulence factors are hemolysin, which it has streptolysin, which is inactivated in the presence of oxygen, which makes it more active without oxygen. The M protein is heat stable and it's an adhesin, so it helps it adhere to the tissues. Streptokinase is a clot buster, basically, so it turns plasminogen into plasmin, which digests fibrin. And it has hyaluronidase, which digests hyaluronic acid, and that's an invasive factor for connective tissues. As I said, it's part of the normal human flora, so the best ways to really prevent it are hygiene and proper hygiene and good health, but it is found all over the world. So here are some questions about part 2. What makes this pathogen ideal for wound infections? How could you distinguish strep from staph on a gram stain particularly? How could streptokinase be used therapeutically? Strep pyogenes doesn't normally cause infection, but it can, so what kind of pathogen does that make it? Another virulence factor is diphosphopiridine nucleotidase, and what does that do? So part 3, the disease. It was determined to be necrotizing fasciitis, which causes subdermal necrosis of tissues in the fascia. And it's very rapid and deadly, and it's mainly the anaerobic environment. So the necrosis causes an anaerobic environment, but an anaerobic environment could also cause necrosis. There are actually 3 types of strep, but the third is gas gangrene, which is not applicable in this case necessarily. So the type 1 and type 2 would be the ones to differentiate here. Some of the predispositions that patients can have would be pre-existing conditions such as kidney disease, liver disease, cancer, different things like that. Diabetes can also be a pre-existing condition. Early diagnosis is key because amputations and death can result. Delaying in diagnosis can have a huge impact on mortality. There was a study that looked at 12 patients who were delayed for 12 hours and 11 of them died. And it can go septic, which can lead to kidney failure, liver failure, things like that, cause the body to shut down. Mortality rates range from about 20% to 80%, and most cases do involve diabetic individuals. And the average age of those who survive is about 35 years, while those who don't survive is around 49 years. And injection and infiltration, such as using needles, can lower survivability. It makes the infection worse. So some questions for part 3. What is a way that this patient could have acquired his infection? What were his risk factors? And what other risk factors might the patient have if he had diabetes? So why would someone with diabetes have a higher risk of getting necrotizing fasciitis? If the patient had not used IV drugs in 24 hours, what would his prognosis most likely be? So if his last injection was 24 hours ago and he has necrotizing fasciitis now, what would his prognosis be? How does the patient's age affect his prognosis? And if the patient is not currently high, what might the reason for his confusion and incoherence be? Part 4, the diagnosis. So necrotizing fasciitis can be a little bit confusing for patients because it doesn't start out as obvious signs on the skin of an infection. It can start with pain that feels like a pulled muscle. And so, and this can also be accompanied with fatigue and vomiting and things like that, which makes it confusing and doesn't lead patients to immediately seek care until the symptoms start, and then it can be too late. It can also look like cellulitis, which is confusing for physicians, so improper diagnosis can also lead to delayed treatment. Culturing body fluids helps to determine the bacteria, so taking the fluid from the pustules on the skin can help to determine if it has more than one type of bacteria or just one, what it is, and that can help to determine the treatment. Type 1 and type 2, as I mentioned before, are based on location and the microbiology. So type 1 is usually monomicrobial, and it's located in the extremities, so the arms, the legs, stuff like that. And that's generally a staph or a strep infection. Type 2 is more on the trunk and the abdomen, and that's polymicrobial, so it has more than one bacteria causing the infection, which can lead to harder diagnosis of the actual bacteria. Another way to diagnose necrotizing fasciitis particularly is laboratory risk indicator for necrotizing fasciitis, and it's on a point scale. So it involves levels of the C-reactive protein, white blood cells, hemoglobin, sodium, serum creatinine, and serum glucose. And so it has different scores, and the different points you get have a different percentage of being associated with necrotizing fasciitis. So an 8-point score indicates a greater than 75% risk of the infection being associated with necrotizing fasciitis. So the patient in this case presented with an 11-point score, and that's significant to his diagnosis. CT and ultrasound can help to mainly eliminate other factors. So an ultrasound is used to eliminate deep vein thrombosis, and a CT could be used to see where the fluid is accumulating. So strep pyogenes is beta hemolytic, catalase positive, and it's a fermenter. So these can be used as culture tests. And distinguishing the bacteria, so you're going to want to culture and determine what the bacteria are and determine if it's polymicrobial versus monomicrobial, because that can determine how you're going to approach treatment for this particular case. Part 4 questions. What could have prevented the patient from seeking care in the first stages? What type of necrotizing fasciitis does the patient have, and how might location help determine treatment? Why are samples taken from so many body fluids? Why is it important to identify bacteria causing the infection? And why does the laboratory risk indicator for necrotizing fasciitis score of the patient say about his infection? So part 5, treatment and prevention. Like I said before, the best way to prevent is proper hygiene, hand washing, cleaning out wounds, taking care of wounds after surgery, anything like that, and good health. So if your immune system is compromised, that is also an opportunity for the pathogen to cause an infection. Also using new needles. So if you do use needles for even getting your blood for testing your blood sugar, injecting insulin, taking IV drugs, change the needles out regularly so that you're not constantly putting that back into yourself. Avoid bodies of water, mostly if you have an open wound or an active infection, because this can spread it, and also you can get the infection in your open wound if you go swimming in a public swimming pool, a lake, something like that. Treatment is mostly strong, broad-spectrum antibiotics, especially at first, because you don't know what the pathogen is necessarily, so you want the strong antibiotics that will work quickly and attack a wide variety of bacteria. Removal of the necrotic tissue. This is important because the necrotic tissue aid in the anaerobic environment, which leads to more bacteria colonizing and creating more of an infection. It also limits the amount of blood that can get to the site, and this limits oxygen and antibiotics, so it can cause more necrosis and inhibit the activity of the antibiotic. So if it's a relatively minor infection, you can use a skin graft to help repair the damage caused by the infection. If it's more severe, amputation might be necessary on one or multiple limbs or different areas. So it's really important to diagnose early and treat early. Otherwise, it could also go septic and cause death. So final questions. Why should you not suture wounds in the wilderness or in the field? Why does necrotic tissue cause so many problems? Why don't we need to avoid beaches entirely, even though they could have these bacteria? How might the approach to polymicrobial and monomicrobial infections differ? And why might changing clothes and bedclothes also help prevent infection? All right, here are my works cited. Thank you for listening.